Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you chose to spend this time with us, and we are going to continue our conversation that we started last week regarding limb preservation. So without further ado, I'll turn it over to our founder, Dr. Randall Maxey.
Thank you so much, Dr. Barbara Freeman. Welcome, Dr. Walks, and Simon and the whole group that's here with us. Last week, I had some bad news about a good friend, Hal Walker, who had passed. He's the guy who did the moonshot for NASA years ago. But this week, I have what I think is some good news, at least on a personal point. I have a brand new granddaughter who was born on Wednesday, or the 7th. She's 6 pounds and 12 ounces, and she's healthy and beautiful. And I welcome her name right now is Beautiful Baby Girl. We'll wait and see what her name is. But we do have a good program today, and we talked about the importance of doing testing of the circulation, especially if you're diabetic. And one of the key things that was brought out by Dr. Kendrick was that it's important to get the oxygen saturation of the toe. So all the other measurements are good and important, but it's very important to measure that toe oxygenation if you want to save those limbs. So let's roll the film, and then we'll have a discussion afterwards. And Dr. Kendrick is a vascular surgeon, by the way, a graduate of Morehouse Medical School.
I'm glad you asked. Guess what blood vessel is one of the last ones to get heavily calcified? It's the toe arteries, or the digital arteries. So these toe arteries are smaller, and they tend to be the last blood vessels to get heavily calcified. Again, heavily calcified vessels mean it's hard to compress them. So we want to compress vessels that are not heavily calcified, and we can do that many times in digital arteries or toe arteries. And so any study that you get from your doctor, okay, if you have diabetes or your family member has diabetes or kidney disease, you tell the doctor, no, sir, I have been educated by a vascular surgeon, and he said that you need to add on a TBI. So if ABI means ankle, brachial is the arm, so ankle, brachial, or arm index, ankle arm index, then what's a TBI? Toe, B is for brachial or arm index, okay? So if you want to call it in your terms, I want an ankle arm index. You want to say that? Because you don't remember the word brachial, then say it. I want an ankle and I want an arm index. If I don't have diabetes, or my family member does not have diabetes or kidney disease, but if they do, you want a what? I want a toe arm index, okay? Toe brachial index, or TBI, or a toe arm index, okay? Now, I gave you a lot of information. Now, the question is going to be, as we get ready for the quiz, how much information you actually retain. I think you're going to do very well on this quiz. I really do. So here we go. Common errors in detecting disease. So let's go with the patient with diabetes. Let's look here. Patient with diabetes. Should we perform an ABI on them? We should not perform that. You guys are doing so well. You're doing so well. And why? If you look really closely at this image, you can see something there that looks like a linear structure. See that line? And you see all that white there? Look here on the back of the ankle. Again, you see a blood vessel. You see all this white. What you're seeing is calcium that's inside. Remember I talked about that steel pipe? Okay, trying to compress that with a blood pressure cuff is going to be very difficult. And so again, what we see is calcium. And that calcium, it can show that it's normal. It can show that it's non-compressible. It can then go back down to normal, and then it can drop all the way to severe disease. So again, in the patient with diabetes, kidney disease, we don't want to use the ABI because of the calcium problem. It's a calcium problem. Okay? Again, what do we use? We use a TBI, all right? A toe brachial index or a toe arm index. That gives you a greater detection for PAD in persons. Why? Because what is the blood vessel that gets the least calcified? The toe arteries. And again, that's why we check it. And who do we check it in? Kidney disease patients and patients that have diabetes, because it avoids a delay in diagnosis and treatment. What do we want to avoid here? A misdiagnosis, okay? So your family member goes to the doctor says, I want to perform an ABI, they have diabetes, kidney disease. You're gonna say what? Not without a TBI, okay? We want to make sure we don't have a misdiagnosis, doctor. So add the TBI on there. Ultrasound. Now this is a big quiz question here yet. We haven't really talked about this. Ultrasound. Now what's happening in the Black community in particular, in all communities, is that there's a push for only doing an ultrasound on patients. Okay? Now, if you do an ultrasound on a patient, what we're looking for is narrowing of the blood vessel. And the way we detect narrowing of a blood vessel is we can sometimes look to find an area of narrowing, okay? Or we can look for how fast a red blood cell is traveling. And the goal is maybe that tells us some information about how narrow the blood vessel is based on how fast the red blood cell is traveling, because you can put something on a red blood cell, on a stream of red blood cells, you can put something on it and you can check the speed, almost like a radar. When someone is throwing a baseball and they can clock it with a radar, that's what the ultrasound does. It can clock how fast the red blood cells are moving through that blood vessel. Well, here's the problem. It may work well in people that have extremely low blood flow. It may work well in them. But the problem is that the majority of patients we're seeing are people that we don't know if they need treatment or not. So in those patients, it's averaging about 50% of the time, it may determine if you have a significant narrowing or not a significant narrowing. Now, if I ask you the question, would you want to wake up every day 50% chance you'll eat, 50% chance you won't eat? I think we want to eat as much as possible because it helps us take care of ourselves. The same kind of concept goes into how we diagnose conditions. We want to diagnose conditions with a better accuracy because it helps us take better care of ourselves. So the reason we do not screen, when I say screen, that means it's the lower cost test to determine if someone is at risk for arterial disease. The reason we do not screen with an ultrasound is we will tend to overdiagnose many times people that are in that 50%. They may get overdiagnosed with having disease when they don't have it. Remember that purple man we saw on the bed? You don't want to start undergoing arterial procedures for your legs when you really don't have the disease at all, okay? Or the disease is not significant enough to warrant surgery. What you don't know is that in the community, many surgeons, that's invasive surgeons, that's interventional cardiologists, that is interventional radiologists, that includes general surgeons, are actually performing the ultrasound instead of the ABI and TBI, are then diagnosing the patients with disease. Okay, we said what happened. Many times you'll end up saying they have disease when they don't. They don't do any other study and they recommend the patient for treatment. We'll call this the purple syndrome, the purple man syndrome, the purple man diagnosis, okay? So anybody that offers you just an ultrasound and they don't do a TBI and ABI, there's something wrong with that picture. And I would say that you probably need to find a provider that's going to give you the best assessment possible. Now, here's what you should know. If you combine these tests together, guess what? You actually have the best option overall on getting it correct. Again, ABI works great in people that do not have. As a screening tool, that's the initial screening tool. This works better in determining if somebody is at risk of the disease, except in what patients? Patients with diabetes and kidney disease. If they do have it, we want to go here, right? Toe brachial index. This ultrasound is a complementary test. It should not be performed by itself. This is a complementary test to complement what we've already been detecting in the patient. Now, when it comes to a screening tool, this is not, all three of these are not a screening tool. ABI or ABI with TBI in certain patients are a screening tool. This ultrasound is a diagnostic tool. This is for confirmation of disease. So we can start here. We can either go here or we can go to, sometimes people will do a CT scan, but other type of studies, ultrasound is not by itself a screening test, and it should not be used to screen, detect, and treat disease alone. Now, why do we need to detect disease? One, we know that, again, if we go back to the start, we said that if we can detect the disease sooner, we can start management sooner on the patients. Why? Because we want that healthy blood vessel that just has those little yellow circles that's moving through. But those yellow circles have not impacted the vessel so much that it starts to narrow it. So that's number one. Number two, why do we need to detect the disease? Well, we need to detect the disease so we don't get a purple man syndrome or a misdiagnosis. We don't want someone treating us or our family members unnecessarily. If we do, we could end up in surgery. The reason I put atherectomy devices here, and I have, I think, the medical student or two on the line, is because this is what we've been working on. We know that if it comes to surgery, first, this is the method. They are actually diagnosing you with an ultrasound. The next step is they then tell you that you need to go undergo surgery. And most of them are providing atherectomy. These devices have not been proven to have long-term sustainability in managing a patient. But guess what? We use them because the billing is so much better, okay? Even though the medical benefit may not be. And so we have to be careful because atherectomy is actually damaging this plaque to try to open it up, but it can actually injure the wall of the blood vessel, leading to, guess what? More narrowing over time. And this may actually close. And I have seen patients in my office that have undergone this procedure. One patient, every month for 22 months, she underwent surgical treatments. She had about 30 stents placed in her legs, both legs, by the time she came to see me, operating on each leg, switching months on each leg. She's now a bilateral amputee. This is a story that is happening across the nation. It is happening in my own family members. So the goal is that why do we need to detect the disease so we can start management early? We need to detect the disease and make sure we're doing it correctly so we don't over-treat patients. And so again, we need to detect disease for medication management. Okay? Question again, do we treat patients with claudication, the cramping pain in the legs if they walk and they stop? Do they often need treatment? The answer is no. People with claudication or cramping in the legs, we said they have the less risk for an amputation. And so those patients usually do not need surgery. They need medication management unless they have difficulty performing activities of daily living around the house or grocery shopping, or cooking, cleaning up, or if they can't perform their job duties. Again, claudication is separate, but we need to understand that why we do surgery. Again, we want to avoid surgery and detect the disease well. So now the question becomes, how do we protect our community? So now we understand what PAD is. We know we need to control PAD by controlling those health conditions. We know that we need to get the diagnosis sooner so that we can start that risk factor modification. And we also know we need to avoid people misdiagnosing us in the community. Well, here's how we protect our community. Does anyone know what this is? Okay. Looks like gold, doesn't it? Does anyone know what this is? Oh, now you're doing a second look. You said, oh, I thought that was gold, but wait a second. The luster here looks so much different. Actually, this is pyrite or fool's gold. This is the gold. Now, the question is, why did I show this? Because we've been talking about misdiagnosis. We've been talking about how to diagnose people, right? But guess what? There is a problem that we are facing in our nation that's likely to place most Black people under the knife unnecessarily. And I call it the pyrite or fool's gold versus the real gold. How do we protect our community? Currently, if you read at the bottom, there's something called the ARC Act. It's the Amputation, Reduction, and Compassion Act. Now, on the surface, you're saying, what is this doctor talking about? Amputation, Reduction, and Compassion Act, all of those seem good. But again, what's in a name? We need to really dive deeper and understand what we're talking about so we can figure out, is this pyrite or is this gold? Well, here are the essential mechanisms of the ARC Act, which has already been introduced in Congress. Right now, it sits at a health committee to determine whether or not it's going to get passed and goes to the House. You're saying all this is happening about me? Absolutely. The Amputation, Reduction, and Compassion Act. Now, the person that authored this bill is no longer with us, but he's a congressman out of New Jersey. Great intent, multiple medical problems, really wanting to do the best for the community. But sometimes, even though our intentions may be great, sometimes there's a missing link. The concern that have and that the Society for Black Vascular Surgeons have had regarding the ARC Act is a couple. One is the ARC Act says that we should screen, again, screening persons with PAD with an ABI. Question I ask you is, should we screen everybody that's a Medicaid patient or a Medicare patient, right? And possibly in the future, everyone that has private insurance, should we screen everybody for PAD with an ankle brachial index? Absolutely, I'm making progress. This is the actual quiz now. I'm just letting you know, this is the actual quiz. You will be graded at the end of this. So you're absolutely right. We don't screen persons with for PAD. You don't screen everybody with PAD with an ABI, and we know why. So that is wrong. We don't support that because of that very reason. This has already been proven. There's no dispute about this. There's no need to push this on our community. And what are we going to do? Misdiagnose people that have diabetes and kidney disease who could have had severe disease that went up into non-compressible. Then they went back down into normal. And the ABI says it's normal, but 6 to 18 months later, guess what? They're actually subject to losing a limb. And those are patients that may have needed a surgical intervention sooner, but they just didn't have symptoms because they had diabetic neuropathy. We have to be paying attention to what's happening to our people in our community. So we know they need a TBI. Oh, the second thing, I gave it away. I'm a bad quizzer. I just gave away the answer. I am so sorry, but some people are probably happy. So the next step is, do we screen persons for PAD with an ultrasound?
Top and bottom.
No.
Timer will alert you when you
The
can.
answer is no. And why don't we do that? Because that largest population of people can lead to what? Surgery. And unnecessary surgery we'll call the purple man syndrome. Our goal is to not get that purple man syndrome by getting people to overdiagnose us with problems we do not have. Now, the ARC Act says specifically, you either diagnose everyone with an ABI or you can use an ultrasound. Now, there's nothing in the literature to ever support that. Why are we doing this? Why are we doing this? Well, guess who the pushers of this bill are? I am. Wait, I said I wasn't pushing the bill. But technically I am, because some of the societies that I'm a part of actually do support the bill. Who else supports the bill besides vascular surgeons? Interventional radiologists. Who else? Interventional cardiologists. Wait a second, wait a second, wait a second here. Wait a second here. Wait a second, is this pyrite or is it gold? So when we go back through here, this is the ARC Act. Diagnose someone with ABI only or diagnose them with an ultrasound. And most people end up using the ultrasound. How do I know that? Because we know that ABIs are only performed in about 33% of medical practices when they did a partner study. I think it was out of Philadelphia, and they found that only 33% of the practices actually had the equipment to perform an ABI. But guess what? Most of them have an ultrasound machine. So this, where do you think our people are going to be? Right here. Getting diagnosed with ultrasound, being sent for surgery, and what? Ending up with a higher risk for amputation. Again, is it pyrite? Is it fool's gold? Or is it gold? All that glitters is not gold. Again, this is who's supporting the bill. Guess who has not made a decision about the bill? Primary care physicians. The American Heart Association. What our job is to do for all of us that are attending here, I said this is not about me. I said it's about our family, it's about our loved ones. Our job is to pass the message, because most of us don't even know this exists. Matter of fact, most vascular surgeons don't even know that this bill exists. And I'm talking about, I've been talking to people from Hopkins. Matter of fact, one of the people that were working of the Vascular Research Consortium at UC Riverside went and published about this based upon her knowledge and understanding about what we've been proclaiming all along. This is not a bill to actually impact our communities very well. Again, it's called the Amputation Reduction and Compassion Act. Now it's not all bad. The part that is good is the last part. A vascular study must be performed before an amputation. Now that just makes sense. What we don't want is to have people performing amputations on people without actually doing a vascular study, because some of those patients may have legs that could be saved. Because what we also know is that sometimes the cost of doing an amputation is greater than the cost of actually doing an arterial procedure. And so we don't want people pocketing money on our behalf and our family members losing their legs. So doing things right because it's right is what's most important. So we say no to the ARC Act. And we say that the congressional members actually need to go back and start understanding some of the science and what's been already proven, what's in the literature out there, so we don't harm our communities. All right, so we tell Congress no. Did you pass? Great, good job. Well, guess what? That's the end of this talk. So first of all, I want to again thank everyone that decided to spend their Sunday afternoon, early Sunday evening, coming out to hear about peripheral arterial disease. I hope that this has been encouraging. I hope this has been a learning experience. But most importantly, I hope that each of you all are advocates for your family, advocates for yourself, and understanding some of these basic principles on what peripheral arterial disease is. Yes, we need to diagnose it sooner. Number two, in Black populations, yes, many times we're not diagnosed with the disease because we have other factors that's happening. But if we start getting screened for the disease, we have to do it right. We cannot take shortcuts in our community with healthcare, because what that will do is lead to further amputations. It'll lead to further compromise where people can't be independent anymore. People ask me, why did you end up in vascular surgery? Well, guess what my first case was when I was a fourth year medical student? The first case I got to do, pushing that general surgery resident out the way when I was operating with attending, was an amputation. And it was bittersweet, because it's the first case I got to do without a surgical resident around me with the attending. But the problem was that it was in a 92-year-old Black female named Miss Brown. Miss Brown was independent, functioning well, walking well at home. But Miss Brown, by the time she came in to see us, had such severe disease in her leg that her leg was not saved. Made me wonder at that time, Miss Brown is now going from independent to dependent. How much is her life going to change? And so there are consequences for us as surgeons operating on patients. That's a serious consequence for many family members that starts to touch more than just that patient. And so my hope is that this talk creates in all of us advocates a way to get this message out and to be able to support. One of the things that we will be doing, Sano Health Arm, advocacy, research, working with medical students, mentoring medical students, high school students, all the way to from pre-K. Our goal is all the way up to postgraduate training. Our community has to come together to understand that we all need to advocate for better care and be supportive of lifting each other up. So in New York, around the NMA convention on August 3rd, we have people from St. Luke that will be there. St. Luke Church is sponsoring this, hosting this for us. But many organizations are coming together to provide free PAD evaluations in the community. Okay, and there's a method that we do it. It's not ABI TBI. We're listening to signals and then directing people to actually get screened. And so one of the things we're doing is trying to get education, awareness out there for people. This needs to happen around the nation. And I look forward to being as supportive as we can. But if you're in New York, it's August 3rd at St. Luke AME Church. And this.
I thank Dr. Kendrick very much for this very educational series. And there's some takeaways I want to start off with before we go to our panel. One is that there's a lot of unnecessary surgery going on from unnecessary procedures. And unless we know the contraindications to these procedures, many of us will have family members or ourselves may fall victim to it. So one lesson is that you can't adequately diagnose vascular insufficiency with an ultrasound, not as a screening test. Another is that we want to look at the oxygenation of the least likely blood vessels to be calcified, especially in diabetics, and that's the toe arteries. And we know that getting a vascular procedure just to dilate blood vessels may not be efficacious and ultimately cause more damage later that can scar over and make the blood flow less. So I think Dr. Kendrick has given us a lot of good points and we're open to discussion. Dr. Neighbor-Stevens?
Well, I was angry at the end of the lecture the first go round, and I'm angry today. One of the things that I want us to leave with is that this presentation contains many examples of how, as a community, we are taken advantage of. And information is certainly a tool, a weapon to fight some of the inappropriate practices that are going on, but it is not enough. And for years, and this is so obvious, but it's deadly. People use legislation, and I'm not saying that the representative who proposed this particular one was trying to be malicious. In fact, he thought he was doing something good and helpful. But when people who are not properly informed are making decisions that's not based on sound medical information, for whatever reason, it can result, and usually does result, in actions that are at the least inappropriate and at the worst potentially deadly. So I'm saying all of this because I think we're going into a season where once again, we went through this with COVID, And we're getting ready to go through a season again of a storm of misinformation and actions being done for reasons that are not necessarily obvious, but are not for our benefit or anybody else's benefit other than the people who are pushing it. And so we have had 2 years almost now where we've kind of relaxed and we haven't been uh, harping on misinformation, say about vaccines or that whether or not COVID actually existed or all of the stuff that we went through. But we're getting ready to start again. And so remember this talk and how we are going to have to defend ourselves. And we're going to have to defend ourselves with information.
Thank you, Dr. Barbara Davis. Dr. Walks.
Oh, Dr. Maxey, I want to second Dr. Neighbor Stevens' position on this. And I think it's hard when we tell people to get their screenings, to go see the doctor, and then we get this kind of information that lets us know that it's not just enough to go to the doctor, but there is homework to do. And I tell folks, your doctor probably has to know a whole lot of stuff about a whole lot of people. And maybe that's okay, and you got the best and smartest doctor in the world, but it really does behoove all of us to know as much about the conditions that may impact us and our families, to know as much as we can. Hence, the opportunities that are presented by Black Health Trust, opportunities presented by other sorts of good places to get information, because we have to go in armed with information. And then the second thing is that how many folks are really comfortable or know enough or ordinarily do tell their doctor what they want. Well, I want this test or I want that test. And so it's important for us to get that information and then use that information in a way that impacts the care that we receive. So when I see this kind of presentation and it on the at the beginning you think, oh, this is great. This is called the Amputation Reduction Act, and it's going to help. And then wait a minute, let me look a little bit deeper. So we do have to get information. We can't just leave it up to the professionals. We can't just say, well, I'm sure that this person knows what they're doing. I'm sure that they're giving me the best care possible. So I won't rant about it anymore, but I think it's important for us to go that next step, get information relevant to us, starting with understanding about our family history and what we are at most risk for, and then being willing to ask those tough questions about can we do this? Is this a part of what needs to happen?
Are there any questions in the chat?
Not yet, but I want to make another comment. Sometimes I get weary, and sometimes I wonder, are we making any kind of an impact with Black Health Trust? And then I heard a story this week about one of our listeners who had his PSA done, and the PSA was just a hair under a 50% delta between the one before and this one. And his doctor told him, don't worry about it. And he said, no, that delta is significant. It's a 50% delta. And he knew that because we've had at least 2 talks on prostate cancer, very good talks on prostate cancer. And he insisted that he receive an MRI. And guess what? He's got cancer. And his doctor was getting ready to send him home come
So
back another year.
it's very important, Dr. Neighbor Stevens, explain a moment, just in case, what delta means, because that is the real meat of what you just said.
The difference between the previous value and the current value.
So it is a rate of rise of the PSA, not the absolute PSA number, but the
Correct.
rate from measurement number 1 to measurement number 2 that tells you the significance of what that measurement is. That's called delta, which is the same as difference between the two. It's the rate of rise, not the absolute number. But if you come back with a number of 25 or 30, that's pretty absolute anyway. Then that's very important. So one of the things this is telling me that we need to question all of the information and its interpretation that we get. So we should not just be telling people the facts, but tell them also how we derive this and what's correct and what's not correct. And maybe in our future presentations, I want them to take the direction that Dr. Kendrick did, where he explained why something is valid and less valid. That's very important that we know how to interpret uh, the information that's going on. So this isn't medical school, but there's a lot of information that we need better explained as opposed to just a lecture, and making sure, as Dr. Walsh does many times, we have to make it understandable. We have to make it simple and have every word defined so we leave no room for questions. Any other
So,
thoughts?
so let me jump in, Dr. Maxey. This may not be medical school, but in support of Dr. Neighbor Stevens' consistent efforts to get us to, this is common sense school. And common sense school doesn't mean you have to know all of the numbers and what all of the numbers mean. But this whole thing about delta or difference is really important across the healthcare spectrum, right? So if I go in and I'm gonna just dip my toe in your area for just a second, Dr. Maxey. I may have a glomerular filtration rate, the measure of how well my kidneys are doing what they're supposed to do, and it may not be absolutely at the top normal place. But if I know what it is, then the next time I go, I can look and see if it's gotten worse, if there's a delta, if there's a difference, if there's a change. All those words are interchangeable. Is there a delta? Is there a difference? Is there a change? And are things changing in the good, on the good side or the bad side? I think that's also true if I can get out of your area and back into my own on the mental health side. Maybe I'm somebody who doesn't want to go out a lot. And so I spend a lot of time by myself. Okay, maybe that's normal for me. Maybe it doesn't mean that I'm depressed or I'm having some sort of a mental health issue. But if there's a significant change or a delta in the way that I behave, in the way that I do things, that's something to take note of. You know, Dr. Walks used to be going out all the time, but now we never see him. Someone should check on me and ask why I'm never going out, why I'm not interacting with people as much. Because it could be anything. Maybe it's a mental health thing. Maybe it's maybe my eyesight is not as good, so I can't go out at night. Maybe my hearing is different. I'm not comfortable talking with people. So this whole notion of keeping track of what's normal for me and what my last value was, so I can pay attention to difference or delta or change, is a huge part of impacting our common sense about ourselves and what we need to do.
Very good. Any thoughts and questions in our chat so we can address any questions anybody has about this wonderful talk that Dr. Kendrick just gave?
I don't like pop quizzes. How about that? No, I think Dr. Maxey, one of the advantages of what Dr. Kendrick did is that so often people want to share information with us, and we're not entirely sure what part of the 3 paragraphs they gave us is the part that's going to be on the test, right? If you take this back to elementary school, right? You get information, and then the important part, usually they used to say, well, if the teacher repeats it, it's important. Or if they come back to it, it's important. And I think when we have an opportunity for that level of clarity where someone says, okay, I'm going to give you some background, I'm going to explain to you what all this means. And now here's the part that I want you to take home. This is the takeaway. Then I think that kind of a lecture can be very useful. And maybe on our side, as the moderators of Black Health Trust, we can encourage more of our folks to pull out those nuggets and make sure that folks are taking the takeaways with them.
Excellent.
Uh-oh, Doctor, I must be in trouble. Dr. Lawson has raised his hand.
Dr. Lawson, sir.
Thank you. I think this is an important and excellent show. It's one that I was always amazed at when I looked at the statistics. I didn't know, I don't know if anyone has any more recent data that they got showing that Washington, D.C. is, I think, second in the nation in terms of amputations. Now, why is that a shock? Well, one, in fact, there's a lot of us there. The fact is that this is a generally well-educated community. What, 5, 6 medical schools in the area?
Right.
And yet, despite all of what we're saying, how we're educating people, I think the message has got out that you should look at your feet and check the limbs and so forth. Somehow, many of our folks in this area are ending up with amputations. And I'd just like to make some thoughts of what's going on, especially if it's happening in D.C. What in the world is happening in the, and by the way, another place that has a very high amputation rate is Bermuda. We already know part of it because both these places also have very healthy, rich diets. But what in the world is going on with our folks?
So I had an acquaintance I made some years ago that wanted me to refer him patients. And he told me about this business he had where they measure all of the numbers of our community with ultrasound and how many of them needed vascular surgery. And he was making a net profit of over $20 million a year. And he was a chiropractor, but he had done a partnership with a vascular surgeon. So all they were doing, a cardiothoracic surgeon, really. So all they were doing is doing the ultrasound tests and coming up with everybody needed to have intravenous percutaneous dilatation of their blood vessels, which gives you very high reimbursement. And so there's a lot of these guys around the community, they don't really have an education in what to do and the consequences, and they make a lot of money, but they're under the radar. So we have to find a way to stop some of this stuff from going on. And I'm just so impressed with what Dr. Kendrick told us. I may ask him to come back on live again one of these weeks just to give a summary of some of the concepts. We can't hear that too much. All right.
Dr. Dawes says that there's a higher amputation rate in Jamaica as well.
Dr. Dawes, are you there? Is Dr. Dawes?
Yeah, yes, I'm here. We have a very high amputation rate. I think from one of the hospitals for diabetics, I just looked it up. It says 1 out of every 1,500 diabetics have an amputation.
Okay. And what he's saying that happens even before the amputation that may lead to amputation, if you do the vasodilatation percutaneously with the balloons, that may ultimately make it worse. So you have to have an amputation. So you go from being functional person to being non-functional. So even if you don't look at the amputation per se, but look at the number of people who are more severe after multiple processes to open those arteries up that don't necessarily need it.
Well, I want to ask you if that is in fact what's going on, or is it end stage stasis ulcers that have gotten
We have
infected,
we
and all
have
that kind of stuff.
we have multiple, I think, reasons. One is we have a high diabetes. We have a large Indian population, and our Indian population here has smaller vessels, including coronary vessels, but also peripheral vascular vessels. I saw a lady on Friday who is 45, not diabetic, who has had 3 vascular procedures already. Interesting enough, she travels, so the 3 of them were done in the US. And she's coming back to me now with severe, well, she's referred by her GP to me complaining of severe pain. So she's had stenting, she's had 2 stents and 1 bypass in her, one in her iliac. I didn't get the actual, I asked them to send me the actual reports, but she's 45. And I'm thinking, this is not good. But interesting in listening to this, those 3 were done in the US because she goes back and forth. And her biggest thing now is that she presented because she says she has pulses in her leg. I have no studies because I saw her briefly on Friday, but her complaint is her left leg, where she had had the procedures done, mostly is weak and dead, according to her.
So another thing that you bring up, Dr. Dawes and Dr. Neighbor-Stevens, there are several types of wounds. There's the one resulting from peripheral arterial disease, PAD, but there's also venous stasis
This
disease,
is
and you have to differentiate between the two, and the treatment is different. And the stents usually happen in people with arterial disease to improve flow. I've had a little bit of experience with wound care, and they both have distinctive types of lesions that into the decubitus ulcers that need to be treated. They're starting to now treat some of these decubitus ulcers with stem cells. So maybe we'll have a program on that coming up, but 2 distinct
right. When I first came to Jamaica, I went to a peripheral hospital, and in my first 6 months, they said I decreased amputation rates by over 70%. So I was actually about to quit because I was sick of all the politics, and they went, no, 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 let's show you some statistics. And that's pretty much by using a lot more drugs, but also just pretty much improving wound care and controlling people's diabetes and cholesterol.
And
But we also use local herbs when we run out of medicines.
Yeah. What was that little medical school you went to?
I went to Harvard.
That's in Washington, D.C., right?
Yeah, in Boston. Yeah, right. But I mean, we have a lot of amputations, but as I said, we have a lot of diabetes. Yeah, I'm on call today too. I'll call them in a minute. But we have a lot of that. And I don't think we have ABIs here. I don't think we can study them. I'm gonna call one of the vascular guys tomorrow.
Yeah, there's a machine called the pseudomotor machine that you want to look at. And I invited a gentleman on who is an expert at that. I don't know if he came on. Is Mr. Sals on? Do you see Mr. Sals, Simon?
No, I don't think so. I'm sorry.
Okay.
So Dr. Maxey, one of the things that I'm noticing is that I think Dr. Lisa is on call too much. Every time. Dr. Lisa, are you on call every day?
Unfortunately, for our hospital, we have 3 seniors on medicine. And right now, because there are 3 of us, so we're on roughly every 10 to 11 days, at nights and weekends. I cover myself. This includes probably today I'm covering over 150 patients.
Wow.
Wow, yeah. So we
Thank-
have
Yeah.
40 something people in the emergency room right now without beds. So
Uh,
people are on chairs, anywhere we can put them. I refuse already 3 transfers today from other facilities to say I just can't. And I know one of them, unfortunately, may not make it because I can't take him.
uh,
You know, let me say this, Dr. Lisa. I think that first of all, uh, we love you. We love the work that you do. It's nice to get data that documents the difference that you make because that can help us to not get as weary in well-doing when we know that we're making a difference. And so it is so important that you can get that information and that you can know that you're making a difference. And yet, and still, it's important to take care of yourself. So I'll leave.
I think I need some help in that. I
Doctor.
think all of us, we were talking that today, all 3 of us are exhausted.
Yeah, yeah.
Yes, we are.
I have an idea for you. You ought to bring one of us down there once a month. One of us will come down there and enjoy the hospital and the beach and spell you something. But that's another program. We're ready now.
Yeah, I mean, I can always give you an invitation. The problem is I can't pay you. And that's, I mean, we can, and that's the issue. I can give you,
Yeah.
I mean, we get 3 for you. We have for Maxi, they're talking to me again about dialysis. I have today they called me about someone who is too unstable to be actually dialyzed right now with a creatinine. Oh, how do I translate it to you? But his last bicarb, I think, was 6.
Oh my goodness. You got
So
another
they're working on him. So this is
Yeah.
all today, by the way. I don't want to get you what's going on just in one day. But this is like a regular day for us. I got called with a platelet count of 6. And the hospitalists where they are, they can't get any platelets.
Oh boy. Well, we'll talk about that. We're at the top of the hour and we'll go for final comments. And thank you, Dr. Lisa Dawes. Dr. Walks?
So Dr. Lawson has had his hand up for a few minutes. I think he like me, he's overwhelmed hearing about the challenges that Dr. Lisa's taking on, but we can get a comment from Dr. Lawson.
Maybe he can make sure we all get to Jamaica.
Well, that's possible. As you know, we actually had a telemedicine linkage with Bermuda and also with Virgin Islands. So, I'm glad to
talk to me. I am sure I can set up. I know the Minister of Health. I know most of the politicians. We're working on something right now. So we definitely can work out, and we have more than enough patients in need.
Right, and also Morehouse has just got developed international center, Harris had been for a long time. So some of our HBCUs have been willing to step up to the challenge. Just need to reach out to them. Second point I'm going to make is that I just came back from Kenya and had a chance to go out to one of our a non-Western providers that is the Maasai and discovered they claim they hadn't had any amputations, even though Kenya has a role as a country has a fairly high rate. So raises some interesting issues about that. And one of the things I noticed in DC is that there's a number of physicians who've had to have amputations. So it doesn't seem to be related to strictly folks' income. We're not just talking about poor people. And it doesn't seem to be just being having African ancestry. So it's a little bit more complex to that, and I think we need to look at that.
I'll talk to the surgical guys that we work with and see. But there are a lot more vascular places now set up in Jamaica. I am not sure it's helping us. They're doing more procedures, but I'm not sure it's helping as much as I thought it would.
Right.
Well, thank you very much. Thanks, Dr. Lawson. Dr. Walsh, final comments?
Yeah, I think Dr. Maxey, that this is a very important show. In addition to Dr. Kendrick's information that he gave us, your comment about these individuals who are looking at banking dollars based on procedures. And Dr. Lawson's comment, Dr. Lisa Kerban Dawes's comment, I think we have to go beyond giving people good health information and continuing to do what we do on Black Health Trust, which is active, just encouraging folks to be more active in advocating for the approaches that will help them to stay healthy. Diabetes is a very big deal, and we can push back on some of those cheeseburgers and some of that ice cream, and maybe kind of get ahead of it. So I can ramble on, but I won't.
I
I
make
just think
one comment on that. When KFC opened in Jamaica, which is probably about 15 years now, it had the biggest opening in the entire world.
Oh my.
So that's the
With
Barbara
all
Stevens.
with all that good food in Jamaica,
Exactly.
folks are going to oh my goodness. Oh,
That's the
okay.
Barbara David Stevens.
Well, I'm going to continue on the same thread that I was on before, because Dr. Kendrick has given us an example in this series of talks, but this kind of activity is going on with other procedures and with other medications. So as I have said so often, be very careful and check out the source and the validity of the information that you receive.
Yeah. Amen.
Okay. I just got a call. Mr. Sauls, are you on? Mr. Dodd? Mr. Thomas? Do you see
Yes,
Tom?
he's on Dr. Maxey. We just need to unmute him.
Can you unmute him?
There we go.
Hey guys, how's it going?
Hi. I want to introduce just a minute, and I don't want this to be a conflict of interest, but we just had a wonderful lecture from a vascular surgeon, Dr. Edwin Kendrick, who's president of the
Oh
Charles.
yeah, Dr. Kendrick. I saw I was at his last presentation.
Okay, so he talked about the importance of being able to get the O2 sat from the toe.
Yeah.
From the toe. And I know you have a machine that not a whole lot of people know about. And he says that a lot of people are using ultrasound only to do screening and make the diagnosis of who needs a vascular procedure. And I want just you to talk about 60 seconds, because we're at the end of our show, just about the name of the machine and the type of machine and what it can do to help.
Yeah, super simple. It's called the TM Flow. It's you're getting an ABI, but along with a TBI, which gives you a 20% more accurate ABI, right? And so if you guys are doing wound care or prevention of amputation, you're going to be able to evaluate the vascular flow early on. Hopefully you get there soon, or sooner than before it's too late. With the TM Flow, you're also detecting small fiber neuropathy through a pseudomotor measurement and endothelial function. So you're going to get the overall health of the vein. You're going to get the lower extremities, a measurement of the vascular and neuropathic systems in the lower extremities. So for diabetic patients, it's very, very useful. It's very good in preventative medicine. It's non-invasive. It's very cost effective, and it's a powerful tool.
No, thank you. In the future, I'm going to ask Dr. Kendrick and you to come on jointly. I'm just so impressed with the information he gave us. I thank you for coming on with such short notice. And
yeah, I'm sorry.
no
Thank
problem.
you for inviting me, though. I really appreciate it.
No problem. And let me just make my final comment on Dr. Lisa Kerban does, that a big opening that happened with McDonald's recently. They didn't have a big opening, but they start selling what are those donuts, Krispy Kreme, and that's been going over real big. So that's also a health hazard to our people. Those things are too good. They ought to be against public health. And the other thing that makes what we want to do in the future so good, that we have to deal with the new potential Secretary of Health that's going to be there doing a lot of denials of things that we know are true. especially about vaccines. So we do have as Dr. Neighbor Stevens and Dr. Walk said, a new lease on life, but we have to make sure we get the correct information out. Thanks everybody for attending this Sunday. Have a great, great day. Have a good Sunday. Thank you, Simon.
Good day, everyone.
Bye.
Bye.